Good evening, everyone, and welcome to the Facial Pain Association's webinar series. My name is Allie Kubik, and I am a facial pain patient, and I'm also on the board of directors. The Facial Pain Association will be continuing to offer webinars, Facebook Lives, and virtual support during the current coronavirus health crisis. If you have not done so already, please visit our website, www.facepain.org, where you can watch past webinars and access our library of quarterly journals. Our next program will be a Facebook Live event. It will be on how facial pain affects marriage and family. It will be on April 6th at 7 p.m. If you're not on Facebook, you will be able to review the recording on the FPA's website and on our YouTube channel. You can continue to reach the FPA and staff via phone or email. During tonight's webinar, Dr. Jeffrey Brown and Dr. Sakula will have a discussion on the controversies of treating facial pain. Dr. Sakula is an associate professor at the University of Pittsburgh, and Dr. Brown is on the faculty at NYU Winthrop Hospital on Long Island. Dr. Brown is also chair of the Facial Pain Association's Medical Advisory Board. Throughout the webinar, you may submit questions and we will answer as many as we can at the end of the webinar. Thank you very much for joining the Facial Pain Association, and now I'm going to turn it over to Dr. Brown.
Good evening, all. I'm not on video. The world is on the internet, and it's difficult and slow sometimes. So I'm going to leave you with Dr. Sakula's beautiful visage and just throw in the questions at him as we go along. So my first question for Dr. Sakula is, this is the age now of telemedicine. Do you believe that's a good thing? Do you use it? And if so, are there any specifics that the doctors or patients need to know in a telemedicine interview?
Well, thank you and Allie for the invitation tonight. I do think it's a good thing. I think it's a good thing because it connects physicians or neurosurgeons who are more experienced in the treatment of a variety of types of facial pain with patients who may not be able to travel to one of us, or that we can rule out from afar that we could help them and save them the expense of making the trip to Long Island or Pittsburgh, respectively. And I think it's quite easy. So I've really been using it for more than a decade. I obviously don't practice medicine across state lines without a license to do so, but so in other words, I can't be giving advice, but I can certainly speak to patients. And we do that through a variety of ways. We used to use a secure portal through our institution. Then most of the patients found that to be more cumbersome. They had to download software. So then we switched to Skype, and then we switched to FaceTime, which is actually quite secure. And that's mostly what we use, although for the past, let's say, 2 years, we've had a pretty robust platform for our own patients at the University of Pittsburgh, but really patients hadn't adopted it until this pandemic. And so now all of a sudden, I just had clinic on Monday and I saw half of my patients through telemedicine, even patients that are maybe not typically as facile with the computer, and they did great. And it was really remarkable. And my guess, and I know I'm not the first to say that, but when all is said and done with this pandemic, I think that there'll be tremendous progress in education, medicine, different areas. I mean, I have 3 kids and they're all doing school online currently. And I think it's a lot for the teachers, but they're all doing really well. They're in day 3 and they're doing great with it.
You know, there's a saying that war is a great source of innovation in medicine. This is a kind of war, so that may well be true. Things will improve. Are there any tips that you can give to the patients in preparation for a interview on the phone or on Facebook in preparation for that? Is there some things that they can do to make it work more efficiently?
Well, I guess I could just imagine your own practice. You've got a very busy clinical practice, and between seeing patients and operating, you probably don't have 30 minutes at a clip to talk to patients. So I think it's helpful if a patient answers the questions that you ask as succinctly as possible, so that you can get at the information that is of particular interest to you, and maybe they're ready to mail their films to you for your review, whatever you ask for. But that's the big thing, is that it's not that you or I are so important, but we do, during the course of a business day, have a limited amount of time to talk. So it's best to try to keep these things to about 10 minutes. And I think you can glean the information that you need rather easily in that amount of time.
This is quite different than what they taught us in medical school, but reality checks more than what we learned a while back. Let me ask you, you mentioned imaging.
Yes.
Is there some special kind of imaging that you would like your patients to get before you talk to them for the first time and send to you? Does it matter to you?
It matters to me. So we published, and there's been other people working in this space as well, but I really started in earnest in 2011 working on high resolution imaging of the cranial nerves, and the literature on that topic goes back into the early 90s, but at least in our own program we started working on it. At that time we were using a 1.5 Tesla magnet, and because we didn't have a 3 Tesla magnet available to us. By 2013, I had convinced our neuroradiologist to allow us to start really working with the 3 Tesla magnet, and I think that there's no comparison. But it's more than that. Obviously, there's nothing special about a 3 Tesla GE magnet that's sitting at the University of Pittsburgh versus another university, or it doesn't need to be a university, a hospital. But there's a lot of tweaking that needs to be done to the protocol. And the biggest problem we have is that when we share our protocol with patients to give to their imaging center, they often don't follow the recipe, if you will. And when they don't,
I have to say that that's universally true, and I don't know why that is, but it is. No matter what we try to tell the other institutions, they don't do it.
Yeah, that's been a problem, and there's some very high level universities that it's amazing the caliber of imaging, how poor it is for cranial neuralgias, and there's a variety of reasons why that's important, but one reason is that if a patient, if a neurologist in Iowa orders a high resolution image for their patient that they suspect may have vascular compression, and the report comes back as negative for vascular compression, then the neurologist may say, hey, nothing can be done for you surgically. Now, the origin of that problem can be from multiple sources. One can be that the image is actually suboptimal, or the radiologist who's interpreting it doesn't know how to interpret the image. And so those are the couple. I'm sure you experience the same problem. So we may have lost Dr. Brown for just a minute, but I'm sure he'll be back on. But when we, so I know he had wanted me to talk a little bit about imaging, and what I would say while we wait for him to come back on is that, having, and again, he invited me on to talk about my feelings and some of you might say are biases. So he and I are friends and been longtime colleagues, but we, like anybody, we don't agree on 100% of our findings. But about 3/4 of the population without facial pain have blood vessels, both arteries and veins, touching or compressing trigeminal nerves. So in and of itself, it's not an important finding. It's when we put together individuals with facial pain and the neurovascular compression, then it becomes more important. And in our group, what we've found is that it's most often not so important that there's an artery or vein just contacting the nerve. What we find to be important, and we've published this, is when there's a blood vessel that's truly deforming the nerve. It's really, grooving into the nerve. And that's not something you tend to see incidentally or in the population of individuals who do not have facial pain. Allie, are you there?
Yes, Dr. Sakula, I do have a question.
Sure.
Are you able to see where this is talking about different controversies in facial pain? Are you able to see neuropathy versus trigeminal neuralgia both on imaging?
No. That's
Okay.
a great question. That's a terrific question. So no, we can't. And so that's why it's so important for the doctor, the surgeon, to really sit with the patient. It can be face-to-face or it can be over telephone. I mean, to me, Allie, there's not a lot of difference between me sitting and talking to you on a video conference than there is face-to-face. I don't love to talk just on the telephone. I kind of like to see your face because there's certain cues that I look for. I mean, and I always say this to patients is that, there's 20 different types of facial pain. And if you have classic or non-classic or whatever form, it doesn't make you a good or bad person. But there are a lot of different types. Classical trigeminal neuralgia, which we can talk about later if you want, is really the easiest to treat. And the non-classical forms are tougher. But just to name a few of them, I mean, you've got classical trigeminal neuralgia that, at least in most cases, has to deal with a blood vessel. About 85% of cases. We know that. We published it in a really elegant group in a Dutch group published that in Brain, maybe 2017, where they looked at 130 patients with classical trigeminal neuralgia, and they found that 85% had neurovascular compression. 85%. What's really interesting, though, is that means 15% of these so-called classical trigeminal neuralgics don't have a blood vessel compressing their nerve. And when we did the study, we found it was an almost identical number. And so what that means to me is that those patients aren't good candidates for microvascular decompression. But that doesn't make them a bad person. And you go down the line. I don't usually use the term atypical. I call it non-classical. I guess it doesn't matter, except when you use the term atypical, it makes a lot of patients feel like they're weird. And the thing is, there's a lot more so-called atypical patients than there are classical. And if you are a basic scientist at all, and I do have a lab, pretty active lab studying facial pain, there's a lot more so-called atypical or non-classical facial pain in the world than there is classical. If I see one classical patient every day, I'll see 4 others with other types of facial pain. I don't
Ray,
want to
this is Dr. Brown. I'm back. I just want to say that there's nothing atypical about atypical facial pain. Do you agree with that?
I really do, and I've heard you saying that for years, and I totally agree with that.
Okay, I'm sorry, I don't know where you were. You go ahead. So I'll continue on my telephone here.
No, I'm okay now. We were just answering a question and filling up the time while we waited for your connection.
So let's talk about atypical facial pain or atypical trigeminal neuralgia. Or you do use that diagnosis, or do you use another term? And if you use that diagnosis, is that someone that you would consider doing any kind of surgery on? And what kind of surgery? And if you would? That's
a
question.
Okay, so that's a great question, I think, for me. I, I basically look to determine, does a patient have classical trigeminal neuralgia? Because if they do, that's pretty easy for me. If they have classical, then I do high resolution imaging, and if I feel, and we came up with a grading scale of how we do, and some people agree with that, don't agree with that, but at least what we do is we look to see what kind of compression they have, and in most cases, even in elderly patients, I'm recommending microvascular decompression. I will do ablative procedures for elderly people or individuals for whom MVD has failed. But
I have to put in a tweak for my elderly professor who's still active at age 85, and he's written a philosophical treatise on the use of the word elderly. Elderly
and what is
bias.
Pardon
His
me?
bias is you could use a word like frail or medically unstable, but elderly is the term of bias. So what's an elderly patient to a 20-year-old may not be an elderly patient to someone my age.
Yeah, that's a good point, but I think you'd have to admit that if you go back 10 years or so, there were very few neurosurgeons performing microvascular decompression for patients above the age of 65. And
absolutely, that's changed.
Yeah, that's really changed. So I guess I'm just saying that if I see an 80 or 85-year-old and they really look to me like they're going to live into their 90s, I'm probably going to recommend microvascular decompression. But to get back to your question, if I've established that it's not classical trigeminal neuralgia, then I try to figure out, well, what is it? So did they have some type of nerve injury from a dental or sinus procedure? Do they have post-herpetic trigeminal neuralgia? Is it multiple sclerosis? But I think what you're trying to say is if it's not any of those, then what do you do for these people? And the answer is I no longer do. I did for years, but I don't do microvascular decompression for those patients. Sometimes, and this is just something I've been working on for the last 2 years. Sometimes I'll take them and I'll do a block through the foramen ovale, just like you do I'd block the trigeminal ganglion with a mixture of steroids and anesthetic. And I've had some success with it. I haven't published it yet. I'm not saying that it's the panacea for people like that, but I will do that. I haven't got into combing the nerve, but I'm interested. What do you do, Dr. Brown, for patients that
you turned it around. So let me go back. How much?
Let me just say one more thing before you answer. The biggest thing that I do for patients with non-classical or atypical is I have a lab across the street, and we're really working hard to try to help those patients with certain sodium channel targets. And that's some years down the road, but we've been working really hard for 5 years in that area, and that's why that lab exists. It does not exist for classical trigeminal neuralgia.
Excellent. This is excellent. But let me ask in the terms of how much credence do you put in your very carefully done MRI scan with those patients?
I'm sure you probably be shocked, but I really follow it very closely. I just don't any longer. I just don't find surprises in the operating room based on the imaging that we're doing, and I think that there,
I say that's not surprising. I totally agree with you there. It's a shame that we totally agree so much, but absolutely, I believe, and I'm sure you believe, that the era of surgical exploration is done. No more exploration. You know everything before you go in.
Yeah, and that's what's so nice is that you have a roadmap, so you don't really have to fool around with the nerve in areas that you don't have to do an entire exploration because you know what you're going for. And I think that the era, and it's not in any way to demean Dr. Janetta, who did so much, but the era of, quote, you just need to go in there and find the blood vessel, end of quote, was certainly very true, even up through 2010 or, but I think that's over now.
I totally agree. But here's my question, because it's been raised. Are there situations in which you do not image a vascular association that you can see that you will operate?
I don't think I understand that
microvascular decompression.
Could you restate that? I don't think I understand that question.
Is there a situation where someone has trigeminal neuropathic pain, the MR image does not demonstrate a vascular association? Would you operate?
No.
To do a microvascular decompression?
No, I would not. And the example I give is to my neurosurgical colleagues is that if I brought them an MRI and said, hey, there's a tumor here in the frontal lobe, you can't see it, but I'm telling you it's there, would you go in and remove it for me? They would all say, you're crazy.
Okay. Now, let me postulate a situation of a patient who's, this is in a discussion of controversies, so I'm going to go into controversies.
Sure.
Patients had a microvascular decompression, whether by you or someone else. It's 3 years later. They have successfully been pain-free, but now their pain returns. How would you go about evaluating such a patient? I'll start there.
Yeah, so what we do is that we re-image them. We add an SPGR sequence in the axial plane because it's pretty tough to see through the felt. But when you add an SPGR, which for the audience is just another really high resolution scan, but you can even with felt in place, you can see if there are blood vessels between the felt and the nerve. And if that patient doesn't have any evidence for a vascular compression, then I go to an ablative procedure. And then I also, whether it's right or wrong, I also have a short list in my head of surgeons that I know are good. So let's say I've got a Dr. Brown patient. They did an MVD. He did an MVD 5 years ago. Patient did great, and then has had a recurrence of pain. I'll do that, but I'm not expecting to find a blood vessel. And maybe the patient moved to my area. Excuse me. So I'm already thinking I'm probably going to follow with an ablative procedure, and I usually do a glycerin procedure.
We're supposed to be controversial here, but I must say I agree totally with your philosophy repeatedly. I want to emphasize it is possible to accurately re-image the trigeminal nerve after a microvascular decompression, and it is possible to determine whether there's been recurrent or a new vessel causing some form of compression. We should know what we're doing in all cases. Now, let me ask, because this has come up, is there any situation in which you believe that the problem is the Teflon felt, and that has to come out?
No.
In a redo after microvascular decompression?
I don't, but if the audience can follow me, and this also kind of is, and I don't mean what we're saying here is so complicated, but it's like if there's somebody in the audience out there that works on carburetors, I mean, they couldn't explain to me how to fix a carburetor in an hour. When you go in, let's say a patient has pain and you assume that it's the felt or the Teflon, and for the audience, Teflon is a form of felt. So some surgeons use Teflon. It's made by DuPont. We use Bard felt. It's just another company. I don't think there's any difference. But in any event, when one goes in and removes that Teflon, in most cases you're causing at least some damage to those outer nerve fibers. Not purposely, but I think that that's a destructive procedure. Now, in my former life, when I did a lot more of that kind of thing, we could sometimes really help patients, and they would wake up without pain. Most of the time, they had some numbness, and so I think that was the reason for that. I also hurt a number of patients very badly doing that, where I caused some severe sensory deficits. So I guess my feeling is that it's mostly a destructive procedure to do that, and I have better ways to injure the nerve via glycerin, or I think balloon's very good. I'm not a big fan of radius surgery for this problem, but anyhow, those are my thoughts.
Again, we're supposed to be in controversies, but I totally agree with you saying if patients get better, in summary, after an MVD to remove the felt, it's probably because we have at least mildly injured the nerve through that operation. And that's the reason, not that the felt was a problem.
Yeah, and what kind of irks me is that, as I said in my former life, sometimes we do that and have fantastic results. And it's almost like we got away with it. But as I said, I could, there's 3 or 4 patients running through my head right now that I remember like it was yesterday that I did that and really hurt them. So,
oh dear.
It's a tough balance there. I think there's better ways to injure the nerve because,
I'd like to interject that we as neurosurgeons enjoy our victories and our successes, but we live with our injuries.
Yeah, definitely. And you when you hurt a nerve like that, you can't reverse it.
I hope not. Let me continue on the recurrent question. If you have a patient who's had, because you mentioned something about this, if you've had a microvascular decompression, you did well, but then the pain comes back, is radiosurgery an option, a reasonable option?
I guess it depends, but my feeling is it largely no. And the reason I don't think it is that, let's say you have a patient and you did a microvascular decompression and maybe they're 87 years old and you think that, of course we don't have a crystal ball, but you think, well, maybe they're going to live 5, 6, 7 years. Okay, then radiosurgery is okay. But in general, radiosurgery works for a couple of years and you really can't do it more than twice. So to my mind, I don't see where you're going with that. I mean, when let's take the 60-year-old that gets a gamma knife and you do it, and let's be generous and say they get to 67 out of one procedure, and that's being very generous. And let's be generous again and say they get to 75 with the second procedure, even more generous, and the pain comes back. Well, now what do you do? I mean, so I just don't follow that line of reasoning, and I again, we're pushing microvascular decompression on the patients we think we can really help with that operation.
I would like to say for the audience that Dr. Sakula is also at the home of the origin in this country of gamma knife radiosurgery for trigeminal neuralgia. So that's a big statement.
Yeah, it is, and I'm sure my partner is not on the line, and I admire him a great deal. He's done some really great work, and there's certain types of non-facial pain cases that I send him every single week. But I'm just not a believer in radiosurgery, generally speaking, for facial pain.
Okay, on to the next area of controversy, as they say in South Africa. There are neurosurgeons. First of all, you're also the home of endoscopic neurosurgery. Do you think that's in any way better than what we would consider microscopic neurosurgery?
No, I mean, I think it's gimmickry. Back in 2011, I switched programs and I was really on my own for the first time. So I was able to do some things that I hadn't been able to do. I was in my 5th year of practice at that time. So, and I'd always used endoscopes, I'm sure like you do, for other procedures, colloid cysts, intraventricular tumors, and I, you know, and I think there's some merit to endoscopes for pituitary lesions, although I think it's also greatly overstated. So I did about 25 MBDs with an endoscope, and you know what I found was that I had to make a larger opening. And I really didn't have the same level of dexterity with the endoscope, even after 25 cases. And I think that if you look at a recent publication regarding endoscopic vascular decompression versus microscopic vascular decompression, at least in hemifacial spasm, Dr. Brown, and I know for the audience, that's just a related condition. That particular I was just stunned that that article was accepted for publication because their overall success rate, if I remember correctly, is about 70%. And if you're an experienced surgeon in that area, you should be above 90%. So I don't know. Are you using
just because you
for
read it in the
trigeminal-
literature doesn't make it good.
No, are you using it for trigeminal neuralgia?
I tried it 25 years ago and said hasta la vista to it.
Yeah.
No, I don't.
Yeah, I think it's mostly, you know, I think for the audience out there, I think it's some surgeon's way of trying to appeal to patients.
And the argument that it was useful is that you could see underneath the nerve with the curved endoscope and explore it, but you already said there's no more exploratory neurosurgery because of the advances in imaging. We know, you know exactly what you're looking for.
Nerve, I can do that with a microscope, you know?
You could do that too. I'm still on the, what about the neurosurgeons who say, no, this Teflon stuff, it's not good. We make a sling and we tie the sling up to the covering of the brain, the dura, or we glue the sling to the covering of the brain, and then nothing touches the nerve at all. You see any advantage in that?
That's a tough question. Again, I think it's mostly gimmickry. You know, I'm sure you would agree it's not difficult to sling these blood vessels most of the time. But, you know, you have straight and circumflex perforators coming off the superior cerebellar artery that is usually, that sometimes can be quite short. And yes, you can get away with avulsing some of those sometimes, but not all the time. And
you want to explain that to people a little bit, what you just said in English?
Sure. Well, you know, the most common blood vessel compressing the trigeminal nerve is the superior cerebellar artery. So it's, you know, it's your big artery, but then there's little hair-like perforators coming off those that are called the straight or circumflex perforators. And, you know, if you really sling that blood vessel, you have a high risk of avulsing or tearing those little perforators. And there's some redundancy, so you can kind of get away with it sometimes, but not all the time. And, you know, I have slung plenty of blood vessels. It's not difficult for me to do. Dr. Brown could do it, but I don't get the sense that that's truly going to improve outcomes in neurosurgery. And the other problem with slinging is that as a patient ages, the blood vessel's probably going to elongate and then come back on the nerve. So I like a physical barrier. Now, for all transparency, do I love felt? I don't love felt because it's kind of sticky and causes some scarring, but I haven't come up with a better interpositional. I haven't come up with a better substance to use. You know,
you just said something people should know. They don't need to know, but they should know that this felt is kind of sticky. And along those lines, have you ever had a patient where you're convinced that this felt, well, slipped, moved, and the pain came back because of that?
No, I don't think so. I really don't.
Okay.
I mean, I had a sling break on me and the patient came back and I had to redo that case.
All right.
And the reason I slung that patient, it was because Dr. Brown, he had so much atrophy, and this is a little bit hard for the audience maybe to understand, but he had so much extra space,
Too much room.
so much
Yeah.
room that I would have had to place so much padding that I was actually worried of what you just said, that the padding may float away. So I decided to sling it, and lo and behold, about a year later, he recurs. I image him, and yeah, the blood vessel was right back on the nerve. So I cost him another operation. And at that time, I did pad it, and that was a couple of years ago. He's still pain free, but so I don't know. I generally speaking haven't had trouble with felt moving.
We're agreeing too much here. We're supposed to be controversial. Let me back up. Go way back to the beginning. And the question is, what do you consider an adequate, quote, unquote, trial of medication before you end up recommending surgery?
Oh, yeah. You sent me these questions last evening, and I appreciated that. I love that question because for me, patients often say to me, I'm just, these medications are killing me. I can't think. I'm so tired. I'm just not myself. And what I say to them is, I don't think you understand, ma'am or sir, where I'm coming from. I'm just going to flip a light on here. It's just getting kind of dark where I am. I don't think you understand where I'm coming from. My only interest in asking you about medications is, did you have a response initially to carbamazepine or oxcarbamazepine? I don't care about any of the other medications. We know from lots of different surgical series that patients who respond to those drugs, at least initially, and I don't mean, again, it doesn't make you a good or bad person, but if you respond, it's a very good sign that you may respond to microvascular decompression. So to answer your question, a patient doesn't need to take it more than 2 weeks.
Mm-hmm.
And I do not believe that patients need to be on medications for a prescribed period of time of a year or two or whatever and go through hell of failing medications. I don't. If let's say you, Dr. Brown, had classical trigeminal neuralgia, you had an MRI showing an artery deforming your nerve, and your doctor started you on Tegretol, and it was like a miracle, and then you started to need higher doses, and you say, Ray, I can't do my work, and you came to me, I'd operate on you the next day.
You're getting dangerously close, Dr. Sakula, to Dr. Takanori Fukushima's statement that trigeminal neuralgia is a surgical disease. You don't need medication, and that is controversial. But you're close. You're not there.
I'm pretty much there. I only use the medication for diagnostic purposes.
So, in other words, if a patient is given one medication and it doesn't work, and then the neurologist usually adds a second medication and a third medication, you're not in favor of the second medication and the third medication to control when the first one has been surpassed in its ability to control, so to speak.
No, I'm not.
Again, we've got to stop this agreeing stuff. It's just, it's not entertaining. We've got to disagree.
I'm really not. Again, now one thing I will share with you, and it was just accepted for a talk at the meeting, but we haven't published it in full form, so it does have to undergo peer review. If you in the audience can follow me, if I'm saying this correctly, what we found is that, at least from our series, is that there's no advantage in doing a microvascular decompression for trigeminal neuralgia in terms of timing. In other words, it doesn't matter if you do it in year 1 or 5 or 10. You still have good results. But I think I don't like to see patients who've been on meds for 10 years and they lose a decade of their life. So that's why I'm saying for the right patient, I'll operate the next day. Right,
that's one of the questions. In Dr. Janetta's paper, he said they found statistically that after 8 years, there was there were not as good results from microvascular decompression after 8 years of documented pain.
Yeah, well, I think that paper, and there's 3 or 4 others, are all methodologically flawed, and I, you'll have to wait to see our paper, but I hope we'll put that issue to rest, or at least others will repeat what we're doing to try to.
Very helpful, because people get scared. Very helpful. Thank you.
Yeah.
Where am I?
But I do want to just restate that one more time. I hate to see patients that have been, and I'm sure like you, I see them all the time, have been on and off of high doses of meds for 10 years and have really not lived a full life, when we could have operated 10 years ago and helped them.
We are, after all,
I'm the first to tell you, there's lots of patients that we see that really I'm not very good at helping. We feel terrible about it, and that's what our lab is trying to address. But there are patients we really can help.
I'd like to make a statement in favor of neurosurgeons. Neurologists very often are afraid in many ways, or they seem to be afraid, to refer a patient to a neurosurgeon. So let me ask you the question this way. When do you think it's appropriate for a physician to refer a patient with stabbing facial pain to a neurosurgeon? At what point?
I mean, almost right away.
I know that you were going to say that. And
yeah,
because neurologists think or fear that because we as neurosurgeons are seeing that patient, we are going to greedily put them in the operating room just because that's what we do.
Well,
I hope we can dissuade people.
That's where with my program, and I know you've done a lot of the same, we've tried to analyze everything we've done. We've consistently changed or adjusted what we do over the last 12 years based on our own literature and the literature of others. But again, for the right patient, we'll operate right away. And for classical trigeminal neuralgia, there's not much role for a neurologist. And I don't feel bad saying that. But again, there's a lot of other problems out there and people on the line who don't have classical. But what was I going to say? I think that I'll give you just one.
By the way, in terms of your diagnosis of classical trigeminal neuralgia, is that based on you interviewing the patient? Do you do specific pain evaluation forms that help you to determine that? Or is it your medical judgment?
Well, I don't believe in the Burchell classification of TN1 and TN2. I think it's harmful. I don't agree with it at all. I don't think people have constant pain more than 50% of the time, or intermittent pain more than 50% of the time. So I think it's really nonsense. I don't think it'll hold up long term. But I do think there's something very unique about classical trigeminal neuralgia, and I do interview them. And so what we're looking for is your pain intermittent, electrical? Are you equivocal about whether it's the worst pain you've experienced? Because I've never met a woman who's had children that has said that childbirth was more painful than trigeminal neuralgia. Every woman I've met has told me unequivocally that this is the worst pain they've ever felt.
That's a significant statement.
Yep.
Again, we got to stop disagreeing. It's very subjective for someone to say less than 50%, more than 50%. It doesn't work for me.
And the other big thing I look for, and not all classic has it, but the vast majority you have, is the so-called sign of tic Delarue, the wincing. I mean, that is classical trigeminal neuralgia. It's very unique, so I look for that.
One of our webinars talked about. I'm going to take you off in a different direction. Rheumatologic causes of facial pain. Let me ask it this way. Are there any pitfalls that you would like to emphasize that we as neurosurgeons or a patient seeing a neurosurgeon might fall into that needs to be looked at when things don't seem quite right? I'm not sure if that's a clear question or not. Are there pitfalls in the evaluation that you believe should be watched out for? That's not good English.
No, I don't know. I'm trying to think. I mean, there's certainly some. I mean, there's a case I just saw last week that I probably should send you. I've never seen this case. This patient is a dialysis patient and has extreme hyperostosis. She's a young woman in her 20s. She's got what looks, really would fit classical TN. There's no blood vessel there. I don't understand this case. I mean, you see things. But generally speaking, I'll send you a picture of it. It's just fascinating. But no, I that hasn't been a major component of my
All right.
practice.
Allie, are you there? I've got 10 minutes for questions that you might have that people send in.
I'm going to just turn some lights on.
Sure. So I'm going to see if I can stir up some controversy between the two of you. Can repeat MVDs do more damage, or is there a certain number of MVDs that you would or wouldn't do if you saw that the patient had a compression?
Oh, well, I mean, if you saw the patient had a compression and this was a classical TN in my book, then yeah, you can do a lot of good. But as both of us kind of stated, you can also do some harm, because if you have to remove that felt, whatever brand the surgeons are using, and no surgeon has a relationship with any of those companies or anything like that, but it's all sticky, and so when you peel that away, you can definitely cause some injury, and it's hard to know how much injury you'll cause. I mean, in fairness, I may be overstating it. Most of the time, we can take it off pretty easily, but occasionally it's not so easy.
I'd like to say that re-operations on microvascular decompression, I have a bias, is a specialized procedure which is best done by those who have experience in doing it. There are certain elements to the operation which one has to be careful about, and those like Dr. Sakula who are experienced in doing it, it's perfectly fine, and I'm not sure that he'll say that the risks of that procedure are any more than the first procedure, but it is not something for beginners. That's a speech. You agree, Ray?
Yeah, I agree. Yeah, I mean, I was fortunate. I spent a lot of time with Peter Janetta, and he had a big referral of these people coming in. So, we worked on that. It's a specialized operation for sure.
Anecdotally, when Dr. Janetta first tried to recruit me as a fellow with him, he said, "I'm going to teach you how to redo microvascular decompressions." That was the most important thing he thought he could teach me. Yes.
Yeah. No, it's a different operation.
How
Go ahead,
many,
Allie.
if we're talking about people are considering surgery, how many surgeons or how many surgeries should a doctor have done in their career? Should they be doing MVDs weekly? Should they be doing them one time a year? Is there a magic number?
Right.
I don't know that there's a magic number, but I think if you, it's not a perfect analogy, but if you, let's say you have a problem with your air conditioner in your car or your carburetor. Not too many people have carburetor troubles, but let's say your air conditioner, you don't just take it to a general service shop. I mean, there's a high chance that it's just not going to be done correctly, or maybe more expensive. I think it helps to go to people with considerable experience. I don't know if
Allie,
there's
we're both quite biased in this. So yes, we believe that, both of us, I'm sure, believe that the treatment of trigeminal neuropathic pain is a subspecialty, not just something that everyone who's trained for 6 years in neurosurgery and general neurosurgery should be diving into.
So if someone goes and their doctor tells them they've done 5 a year, that's not enough?
Well,
I don't know. I mean, maybe that person's done a lot formerly earlier in their practice, and then their practice changed a little bit, but they still have a real good handle on it. But
Okay.
I mean, let's just be blunt. If you're seeing someone who's 5 years into practice and they've done 25 of the operations, wouldn't be my preference.
Okay.
It's a unique area. Don't you agree, Jeff?
I totally agree, and that's the speech. And by the way, one should see a neurosurgeon like Dr. Sakula who can do more than one thing. It's not like they're the best in the world at MVDs, and if you don't need an MVD, then go see someone else because that's all they do. And if you don't do well with the MVD, then go away because that's all they do. This is a subspecialty of medicine, and you need to be able to treat people from multiple different approaches and not just toss them away because the one thing you do better than anybody else didn't work. That's a speech. I'm sorry.
Yeah, I agree.
Talking about being a surgeon, being able to do different things, is there, what is the success rate of an MVD after you've had Gamma Knife or vice versa? Or can you have both?
Yeah.
You're the expert there.
Well, we published on that. The results, the favorable results are pretty darn similar. What we found, at least, gosh, this goes back almost 10 years ago, is that the rate of numbness that we caused, permanent numbness, was about 20%, whereas in our regular cohort without Gamma Knife, it's about 5%. Now, I'm 10 years more experienced. Maybe we're causing less numbness. I don't know. We have to look at that again. But we did find a little bit higher rate of numbness because the nerve just doesn't have much reserve after it's been radiated. But still,
that's another important statement that Ray just made that I'd like to emphasize. That we talk about series of 1,000 patients over a career that are published, and that elicits certain percentages of complications. 3% of hearing loss or 3% of facial weakness. But that's over 1,000 patients over 30 years. You really got to believe that if you look at the patients in the last 5 years or 10 years, that complication rate might very well change because of experience. So what's published as accepted rates of complications have to be understood a little in terms of the length of the series. It takes a while to develop big numbers.
Yeah, it sure does. And I mean, there's no question that, I've seen a lot more, but again, occasionally I have novel findings in the operating room, but I'm so much more experienced. I'm better able to handle it. I mean, I think we're both still getting better.
The most important thing about that experience, again, I'm going to emphasize what Dr. Sakula just said. It's the ability to identify what's different and understand that it's different, which comes with experience. That's very important to say, hey, that's not right. There's something different here and it shouldn't be treated the same way. That's very important, and that can only be after one has seen an awful lot. Along those lines, can I ask, how much credence do you put on the report of the radiologist when you get an MRI from another outside hospital?
Oh, I don't.
Thank you. And patients should know, just because the radiologist said if the trigeminal nerve is normal, that doesn't mean that they should not see a neurosurgeon. It doesn't mean that they may not be a candidate for microvascular decompression. The report is also...
I used to have a folder in my office from all of these elite institutions in the country that said, negative, normal trigeminal nerve. And I thought, I'm going to publish this. But then I thought, no way the editors will take this. But, it would have been a really interesting. But it's very
Right,
harmful because that those patients are then, we don't know the denominator out there. There's just thousands of patients who are told you can't be helped.
So that's the purpose, to summarize up, of our discussion, is to help those hundreds of you out there as best we can. And just because we're going to finish talking in 1 hour, that doesn't mean you don't have questions that can't be answered. So please send on any questions that we haven't answered. Send it to the Facial Pain Association. The Medical Advisory Board is there for us to answer for you or to help you or to find referrals for you. Dr. Sakula, of course, is a member of the Medical Advisory Board. And I want to thank you all for listening, and I hope we've been of help. And I want to especially thank Dr. Sakula because I agree with him on so many things. It just makes me feel good. And I hope he can make you feel good too. Thank you very much.
Well, I thank both you and Allie. This was really a lot of fun, and I hope it was helpful. And, I would just end with, when you talk about seeing a doctor for this condition, I think you can hear the enthusiasm in Dr. Brown's voice. And I certainly have enthusiasm. I got bit by this bug of treating patients with facial pain when I was a first-year medical student, and wrote to Dr. Janetta, and Dr. Brown had a similar situation, I know, and it just kind of never got out of my system. And that, bug has caused me to spend a lot of time thinking about these patients.
That's interesting. We could talk forever about that. You wrote a letter to Dr. Janetta. That's exactly what I did. That's interesting.
Yeah, and he wrote back to me, thankfully.
He looked for people who were interested in his field. Good for him.
Yeah.
I miss him dearly. Thank you all.
All right,
Thank you,
thank
Allie.
you. Thank you everyone for joining us tonight. If there was a question that you missed the answer to, we are going to notify you when the recording is available on our website. And also just a reminder that we have 2 events coming up. Our next event is going to be a Facebook Live, which is going to be on the topic of how facial pain affects marriage and family. It is on Monday, April 6th at 7 p.m. And then we also have another webinar scheduled for April 15th. Thank you very much for joining us. Please contact us at info@tna-support.org with any questions you have. Thank you very much, everyone, and have a wonderful evening.
Thanks. Good night.